Tonight is one of our SWAT talks about racial justice, and we'll focus tonight on health policy, ethics, and equity. And in these SWAT talks in racial justice series, they're structured as a discussion. Really, we'll start the hour off with questions for Carolyn and Maria Elena about their work, and then they can have a chance to answer those. And then as that discussion is continuing, everyone on the webinar, there's 102 of us now, which is terrific, can post questions in the chat, and then I'll ask them to our panelists. Please, when you post in the chat, please post your name and also your connection to Swarthmore, your class year, or if you're a parent or otherwise connected to the college, that would be great. So this evening, we're going to focus on the impact of experiences of racial profiling, surveillance, and deportation on the well-being of immigrants and others in our society. We're going to talk about issues about life expectancy in rural white communities and how that has declined and how that has impacted rights and freedoms. And in general, we'll talk about the connection between healthcare disparities and racial disparities and socioeconomic status disparities and their impact on healthcare. A very timely feature, given everything that is happening right now, especially with COVID. And as that pandemic evolves, now we see access to vaccines as being one of the other things that are unequal across our society. Let me begin by introducing the distinguished scholars who have joined us. Dr. Carolyn Rouse is a professor and chair of the Department of Anthropology at Princeton University. After graduating from Swarthmore with a major in anthropology and sociology, Dr. Rouse obtained her PhD in anthropology from the University of Southern California. Her research, as we'll hear about, focuses on race and inequity in religion, medicine, education, and economic development. And she's the author of several books, including one that I think is just came out or is coming out, Developmental Hubris, Adventures Trying to Save the World. And we had a tremendous discussion as we were just starting, with wide-ranging from literally from genetics and epigenetics to race and inequality. Looking forward to her discussion this evening. Dr. Maria de Trinidad Young is an assistant professor of public health at the University of California, Merced. After graduating from Swarthmore with a major in Spanish literature, she went on to Berkeley, where she obtained a master's of public health, and then to UCLA, where she received her PhD. Her work focuses on the impact of the US immigration system on the well-being of immigrants and their family. And she's contributed to the growing evidence that immigrants who lack citizenship or legal status face unique barriers to healthcare and well-being. She's been a voice in, particularly in the American Journal of Public Health and elsewhere, really, it seems like every other year, publishing an editorial on this topic and making her voice heard to try to address issues of structural racism in immigration policy. Thanks, Carolyn and Maria Elena, for joining us this evening. Let me start with a question for Dr. Rouse. Dr. Rouse, what have you learned from studying the declining white life expectancy in rural communities?
Thank you, Ted, and thank you to everybody who's here. This is a wonderful opportunity to share with the SWAT community questions about racial disparities and where we are with this. So I guess I'm going to just start off with a story, and it may seem like I'm not quite answering the question, but it's because the question's a little complicated. So I had always been interested in racial health disparities, and in the 1990s, I was making a film about community workers in California. And I had worked with this woman, African-American woman, who was working with these African-American homeless kids in LA. And we went and filmed them, and they were talking about their aspirations. You know, I want to become a mortician. I want to, they had all these dreams, right? And I was so familiar with this because of my work with African-Americans. African-Americans have tended to be very aspirational, and you can, if you go to a church, you will hear that, you will see that. There's a lot of community support. The idea of you have to be your brother's keeper, your sister's keeper. And then I drove up with my film partner to a rural place in California called Susanville. And again, this was in the middle of the 90s. And we were filming basically the same kinds of populations of teens. And there was a meeting and about trying to teach them about, reproductive health. And they asked them, what do you want to do? And the kids couldn't articulate a dream or an aspiration. And then I heard stories about, I heard the story of a woman who lived in a trailer with her Vietnam vet husband, who was a drug user, and their 15-year-old was a product of rape, and she had been disowned by her family, and she was depressed but didn't have the language to articulate it, and this community health workers trying to help her. And then my friend and I drove to this little town with a population of maybe 100, maybe less. And there was the iconic red, little shop in the middle of town. And we were saying, hey, we're here, we're studying health. And she said, oh, you should go meet this woman over here. She's had to foster over, 36 kids. Because of the drug use, meth. I'd never heard of meth. I feel like I was so naive. And we went over and talked to her, and she said, oh yeah, my neighbor, he came over and he was beating the dog, and he killed over and died. He was a chained up dog. And then he was tested, and the body was tested and had HIV, and so AIDS, he died of AIDS. So the whole family was tested. They all had HIV, and they all ended up dying. And this was a tiny little town in rural California. And I came back and I called my sister, who's an economist, and I said, white people are in trouble. I mean, I didn't know, this isn't something that we were studying at Swarthmore. We were studying Charles Murray and his whole analysis about Black people and their inferiority, cultural and otherwise. And a lot of the talk was about empowering Black people and a lot of the focus, but what about white people? But of course, I'm still interested in white people. So I went on and have done work on race. But in the, around 2015, I was in Ireland with Angus Deaton, and he and Anna just published their paper on declining white life expectancies. And they were, sort of they were wondering why, right? They were trying to come up with answers. And it was all sort of rational actor answers. The idea that, oh, it's because, their parents have less income, so there's just the people aren't just as motivated because it's a sort of a rational actor. They're not inspired. And I thought that's not it really. I mean, anthropologists struggle with some of the basis of utilitarian economic theory and the idea of the rational actor. So I said, I'm going to go back. And then my primary interlocutor happened to be listening to Fareed Zakaria when he was talking about Angus Deaton, and Angus Deaton had cited my work. And so she called me and she invited me to this county in California to do field work because she said, yeah, you got to come here. And sure enough, I needed to come there. So, and let me just be clear. I think a lot of people are disinterested in whiteness and health. Because, and in some ways, maybe rightly so. I'm not asking anyone to pity these folks. Many of them are from upper and middle and upper middle class homes, and they fell down the economic ladder. And some of them are racist, and they're not perfect people. They're not sort of objects of respectability or people, but that's not, our humanities, we're all human. And I think that if we care about the least of us, then that's a very important thing. But that said, why am I, people ask me why I study them. They've had all these opportunities. In fact, some of them have inherited enough money to buy a second home in this area and rent it out. And, so it's not as though they are without resources, but they're passively suicidal. They're killing themselves by drinking a lot, drugs, just basically not taking care of themselves. But I'm interested because of the American narrative of progress and the idea that we thought somehow what we were doing was taking us into this direction of better health, more wealth, I guess more happiness. And these declining life expectancies indicate that there seems to be something wrong with the narrative, or maybe we're not getting something right. And to me as an anthropologist, this is really fascinating. And so, just to move on, to shorten this, basically, again, it may sound tangential and not directly addressing your question, but we really do have to go back to the Industrial Revolution and a time when we had built an economy of things around the idea that a person's value and income should be based upon the production of things. And we also had a society that exploited people who produced these things, right? But people still have in their heads that that's the right kind of society. So we have an economy of things, but we don't have an economy of care. And so these people are still invested in that economy of things. And they think that we need to return to that economy of things. And they have not processed the fact that this is an economy built on exploitation, and it's an economy that's going to destroy the environment. So I'm really fascinated by this kind of all of the care work that could create a new economy in this area. There's a lot of caring that's going on, people taking care of sick people, mentally ill people. We could create a different kind of economy, but again, they're still invested in that old economy. And their racism also is part of that too, right? So they feel as though when their parents were middle and upper middle class, the structures around them supported parents who were alcoholics, right? And drug users, because women weren't allowed in, and immigrants really weren't here, and blacks, and right. So but when women gained rights and immigrants started moving in, and African Americans with the desegregation, they had to compete, and they don't like that competition. So they're invested also in a system where, because they really think the cream rises to the top, and the only reason why African Americans or people of color are gaining on them economically is because the government is supporting them. So they want to get rid of the government. And so they want their independence and their freedom. And that means freedom from the Affordable Care Act. That means freedom from all of these things that would actually help them. Because they really think that, well, then the cream will rise to the top, and that will be me. And it won't be those immigrants, it won't be those Black people, it will be me. So it's a combination of a lot of things that I connect to the way in which we think about what an economy is, which is a cultural construct. But it's also these investments in a particular type of economy and social system that is that should be long gone, that does not promote the health of the population. It promotes the health of a group of people. And so they're caught up in this. And so they're quite proud of the fact that they don't want the government to tax them on cigarettes. They don't want people to come in and tell them not to drink. They don't want any kind of oversight of public health. They want to be quote unquote free. Of course, they get government support at the same time, but it's all because of this sense that they're entitled in a way that other people aren't. So again, they're not to be pitied, but I think it's a really important thing to note that in a society of great abundance, you can have these declining life expectancies, completely challenging our narrative about progress in this country.
Thanks, Carolina. It's striking, and especially striking in the sort of healthcare arena. And I remember hearing Elizabeth Warren during the primaries speak here in Iowa, and about, with this sort of answer to everything. But what was missing in many of that was this question about care. And I mean, it's missing in all of politics, really. They're set up to have these massive solutions, but at the end of the day, what builds society is individuals caring for each other. And that's something that cuts across all of it. It's interesting to hear that perspective. I see that we're getting a couple of questions, but let's let Maria Elena tell us about her work, and that your discussion about health at the end and the Affordable Care Act is a good transition to that. Thanks, Carolyn. Where Maria has focused on the relationship between health status and racial profiling, surveillance, and deportation in immigrant communities. And she's focused on that in Latino and Asian immigrants in California. Dr. Young, could you tell us a little bit about your work in that area?
Yeah, hi, everybody. I was gonna say good afternoon. It's still pretty much afternoon over here in California. Good evening to my East Coast friends. It's wonderful to be here and just get to have a swati chat. And it's really just so fascinating, Carolyn, what you shared. And I think a really great bridge into the work that I've been doing is sort of thinking about the role of government, right? And it's so fascinating to sort of think that of the populations that you've been studying, this perception that the government is sort of giving a leg up to immigrants. My work really focuses on trying to understand how immigration policy shapes public health. And I really come from the perspective of thinking about how immigration policy sort of actually bolsters structural racism, and how immigration policy is kind of sort of perhaps the very opposite of what the individuals that Carolyn has worked with might suggest, but actually really is very involved in perpetuating inequities that disadvantage immigrants and really can be a real risk to their health. So one of the big challenges today that immigrants living in the United States face is that they're navigating lives, going to work, going to school, accessing healthcare in a patchwork of very complicated, often contradictory government policies at the federal, state, and local level. So some of these policies are actually inclusive. So for example, in California, we've enacted policies that expand rights and eligibility for public services of people regardless of legal status. So if you're an undocumented child in California, you can sign up for Medi-Cal, which is our state Medicaid program. If you're an undocumented immigrant, you can get a driver's license. So there are some of these policies, particularly at the state and local levels, that are trying to integrate immigrants, provide them access regardless of their citizenship status. But on the whole, a lot of the policies that we've seen enacted really over the last 30 years in the United States are largely punitive and exclusionary, and target immigrants with surveillance, sort of using legal status as this line of watching and sort of excluding immigrants, really in focusing on profiling them, and this very much kind of leads into just racial profiling immigrants, and then ultimately resulting in the deportation of lots of immigrants. So in my work, I really wanted to understand sort of how do these policies, what do they look like in people's lives? And so with colleagues at UCLA, I've been working on a multi-year study where we've conducted a large survey here in the state of California. We did a phone survey of 2,000 Latino and Asian foreign-born adults to ask them about their experiences with policy, and then also 60 in-depth interviews with specifically Mexican and Chinese immigrants in Southern California to sort of get a little bit more of the rich stories behind what we were seeing in the data. And I want to talk a little bit about sort of what we found specifically in that survey. So the survey was really asking people very targeted questions about potential forms of exclusion that they might experience under this patchwork of policies. So for example, we asked people, had they been denied a medical interpreter at a doctor's visit? And that's something that's protected under California state law. We asked people, had they experienced wage theft? That's something that should be protected under both federal and state laws. But specifically when it came to kind of issues of like immigration enforcement and policing, we asked people a whole series of questions about whether or not they had encountered immigration officials in their neighborhood, if they had been asked to prove their citizenship to a law enforcement officer, if they had been racially profiled, or if they or somebody else that they knew had been deported. And the idea was to sort of try to understand all the different ways in which people's lives intersect with this system that we've created, the system of immigration enforcement, which again, I argue is really a system of structural racism. And I'll highlight just a couple of key findings and happy to take more questions about it. So first, I think one of the things that's really unique about this study is that we included Asian immigrants. And when you look at the research, or just, I think even, I mean, most of you are, I'm sure, reading the New York Times, when you look at immigration enforcement, deportation, the stories largely feature Latino immigrants. And that's, you know, makes sense that it is a large group and are very much targeted, but there's very little knowledge about Asian immigrants and how they might be sort of racialized by our immigration enforcement system. So our first sort of general findings were, to a certain extent, confirming what we already knew about Latino immigrants. They reported high levels of surveillance and profiling. So for example, 10% of our participants, Latino participants, reported that they had ever been asked to prove their citizenship to a law enforcement officer. That's 1 in 10, that's pretty high. 15% reported that they'd seen immigration officials in their neighborhoods. So this sort of confirms sort of what we already knew, that Latinos are living in an environment of enforcement. But we also found really what I would say are significant non-negligible levels of exposure to enforcement amongst the Asian respondents. So for example, when it came to racial profiling, amongst Latinos, 15% reported that they'd ever been watched, sort of surveilled by a law enforcement officer, and 15% reported having been racially profiled. Among Asians, 5% reported having been watched, but 10% reported having been racially profiled by a police officer or a law enforcement officer. And so, you know, these are kind of numbers that I think haven't really been in our conversations about policing and immigration enforcement, and I think are important to highlight. And then finally, when it came to deportations, 45% of Latinos reported knowing somebody who'd been deported. This is pretty consistent with other national surveys, but we also found that 10% of Asians knew somebody who'd been deported. So again, I think these are numbers that we sort of need to bring into the conversation and sort of understand how our system creates different forms of racial inequities. And then I'll just sort of end and sort of, when we took this survey data together and did all the kind of fun statistical modeling stuff, I think really the key finding that emerged is that it's not necessarily person's exposure to any one of these experiences that shapes health, but it's their overall cumulative experience. So participants reported greater numbers of these experiences had higher chances of reporting worse health, and also had higher chances of reporting emotional distress. And I think this is really important too, because often the way we talk about enforcement, we sort of focus in only on one topic, you know, just deportations or just racial profiling, and it's sort of it's easy to forget that these are all specific mechanisms that together function to create a system that are a risk to well-being. So I'll leave it at that and take more questions later.
Thanks, Maria Elena. Yeah, one of the things we talked about before we got started was this idea of stress and stress's impact on physiology and on psychiatry and on emotions, and those are differentially experienced by, you know, if you're approached by immigration often, or where your community is like, can really have an impact on that for sure. We're getting a number of questions, which is terrific. Please, if you have any, chime in. There also are some comments, which are nice too. So thank you all for those. And I want to start with a question that we were going to talk about next. And one of the people in the audience, John Uri, has asked. And that relates to this, racial disparities in healthcare, particularly related to COVID-19. There's an article in the New York Times, an op-ed piece calling on the president to declare racism a public health emergency. And that piece points out, looks like we lost Maria Elena. So here's one from Cynthia Gray. And she says, you know, we used to have a caring economy that was underpaid. We have lost that caring economy as women entered the workplace. Do you have thoughts on how to reclaim or recreate or develop a more caring-based economy?
Thank you for that question. So some people may react to that question as, oh, that's a sexist question. There was care when women were home, but she's raising a really important point, which is that, we have an economy where we have often two breadwinners, let's say Princeton professionals. Oh, should we go to
No, go ahead, Carolyn. We'll
and
I'm back.
and so
Glad
it's
you're back.
actually increasing economic inequality. So you're having these communities like Princeton where you have two, a doctor and a lawyer live together and are making tons of money, and then raising the cost of housing in the area. We really don't. So it's not even just that we don't have care. There's not somebody who's sort of responsible for the emotional labor in the home. But we also have these radical forms of inequality because we think that a family requires, with two professionals, should have two, breadwinners. And we seem to be forgetting the importance of emotional work. And, I personally experienced this when my husband died 2 years ago, and he had kind of gotten off the track because he had cancer. And when he died, it was just, he was doing all of this emotional labor in my home that I was free to, build my career as he's doing this, and my kids needed it. So literally in the past 2 years, I've learned to text my children, like that wasn't a thing I had to do. And what would it have meant if he hadn't been doing that? And so in this kind of rat race for more money, for more things, right? This economy of things is all about more. We have lost the fact that, home life should be. So I think about how we're hoarding labor. A lawyer who makes $2 million a year could choose to make $500,000 a year and have 3 other lawyers, and they could maybe have their weekends free and get home by 5 p.m. But we don't think in those terms anymore. It's all about this kind of hyper performance, and then massive amounts of money that go with that hyper performance, as opposed to thinking, why aren't we just sharing the wealth? And so so that we have more people who feel comfortable and secure and safe, and with a safety net where they can do that very important emotional labor in the home, taking care of elderly parents, taking care of people with disabilities within their home. There's all sorts of, so I agree. We hate to use that idea that, it was better when, because that's not what we're saying. It's what we're saying is we have to rethink this whole thing, I think. So.
Thank you. Marilena, thanks. We're glad you're back. And
I'm sitting closer to the wireless, the Wi-Fi router now. So hopefully that'll.
Great. You're teleported back to us, which is good.
Exactly.
We'll go back, so jump to a question, particularly for Carolyn. So we'll go back to this issue of declaring racism a public health emergency as a question for you. And I think I was looking at this op-ed piece in the New York Times, and the Black and Latino people make up 13 and 18% of the US population, but they account for more than 50% of the COVID hospitalizations. And thinking about Asian immigrants, as you mentioned, and the virus has killed a disproportionate number of Filipino nurses, is one of the things that this article points out. And Native Americans have been nearly twice as likely as white people to die from COVID-19. So how have COVID-19 and its policy responses, how has that impacted the immigrant community, for example, that you study in California?
Yeah, I mean, so when COVID started, I started a small study that's kind of quickly grown to talk to Latino immigrants in rural parts of California. So UC Merced is located in the heart of the California Central Valley. So it's a rural and agricultural region, and it's really powered by the labor of immigrants, not just Latino immigrants. It's longstanding Yemeni, Punjabi, and Bangladeshi and Hmong populations here in this region. Just because of kind of language, I've mostly focused on Latino immigrants. But I think one of the big issues has been around having to work without a safety net for being able to opt out of work and stay home, immigrant workers have been at the front line of kind of keeping people fed, and we kind of like lionize like essential workers as heroes, but it's not heroics, it's necessity. And you really see that here in the Central Valley. We've had some of the highest COVID rates here. And I think one of the things that to me is just so striking is when you talk to people and ask them about their concerns about COVID, everybody we've spoken to does their best to, in this situation they're in, engage in social distancing, mask wearing, but can only go so far if they still have to go to work. People we spoke to were buying their own masks because employers wouldn't provide them for them. And a lot of the messaging around COVID is very focused on behaviors. Like we need to talk to Latinos and make sure that they know what to do. It's like, no, they actually do know what to do, but they are doing it in a context where they have no other choice but to work. And so these sort of, I think there's been a good shift in terms of people's understanding that these disproportionate rates of COVID deaths and hospitalizations in communities of color are not just because of bad behaviors. I think there's been a good shift over the last year in that, but I don't think there's been really a reckoning with the fact that people in this region do not want to get tested, because if you get tested, you're human, you want to do the right thing. You will ethically stay home and lose 2 weeks of salary, and you might be out, you might not be able to pay for your rent that month. And so people are not willing to even sort of kind of come forward and do certain types of, testing or getting vaccinated because of fear of the impact on their economic stability.
Yeah, the other aspect of this is we think of COVID as in the treatments of people that wind up in the hospital and eventually in ICUs and on respirators. But I'm at the University of Iowa, Carver College of Medicine, and my colleagues here, they've really focused on just kind of standard of care early on in the disease. And one of the challenges, for example, is that this loss of smell and taste means that when individuals with COVID drink, they have like this dirt taste, some of them, and it's difficult to keep eating and drinking. And so there's small things about like keeping hydrated and early in the illness that can make a difference in the disease progression. And that's something that's really going to be impacted in a culture or a group of immigrants where they have to work. That's also part of they need the money, obviously, but it's also part of their culture. And so they're not only not thinking about getting tested, they're not considering the fact that they would have to take care of themselves, right? And the little bit of care of hydration and et cetera is a small thing, but it can make a bigger difference if it happens in the beginning of an illness. Of COVID-19 illness. So there's that too, that it's not, you don't always need access to the very, very high end medical care, but what you need is the ability to focus on taking care of yourself, right? And
absolutely, right, just rest. I mean, being able to take time off work.
Right. That's absolutely right. One general question I had for both of you, and I don't know, is about this relationship. You talked about a very local community, Maria Elena and Carolyn, you did as well. And one thing I wonder about is this interaction between local governments, state governments, and federal governments. It seems like you clearly have this patchwork of regulation with some levels responsible for this and others responsible for that. But could you comment on that? And if there's part of that, if parts of that are a solution or parts of that are a problem?
I'm going to hand that to
do you want to start with that?
Elena.
You want me to go first? I mean, yeah. So I mean, I think it's such a fascinating question, and I mean, this is really like gets at the crux of my research, looking at different varying levels of immigration policy. And I think that one of the benefits is that we can do things in local communities to expand access to sort of try to undo some of those mechanisms of structural racism. So we see some of the, New York City, San Francisco, Los Angeles have done programs to expand health coverage to undocumented immigrants, right? And so I think those are really positive examples. I think where it becomes really very problematic, and we are now seeing this play out during COVID, is that the federal government can often be at odds with what states are proactively trying to do to support their populations. And so I'll just give like one very specific example, because I could bore everybody for like hours with other examples, but Trump spent, former President Trump spent, years trying to enact what's called the public charge rule. And this was a regulation in federal immigration policy that essentially makes immigrants ineligible for obtaining residency if they use public benefits, right? So he spent years doing this, trying to ram this through the courts. It was blocked, it went forward. And then COVID hits, and people in states, even if the state of California is trying to give cash assistance to undocumented families, even if they're doing kind of local efforts to try to expand testing, you've got this federal messaging saying, if you use public services, you could be deportable, you could be ineligible for a green card. And so we see this time and time again, particularly in immigrant communities, of these contradictions that essentially make state and local level efforts, a lot less fruitful. And I think it really means we have to sort of look at, particularly in immigration, look federally to make certain changes.
Yeah, there's one of the people here, Erica Orsman, thanks for your question, which was related to this and helped inspire it. She works at the CMS, which I think is the Center for Medicare and Medicaid Services with the government, is talking about she was mentioning the new administration's goal of prioritizing more diversity and inclusion, but there's a lot to overcome there. And so Carolyn, could you comment on that interaction between kind of local and state and federal governments in your areas of research, and how that has impacted things?
Well, I just want to echo what she said. I think that health is pretty local. I think Flint, Michigan is an example, right? Environmental exposures, what they do. Where I work in a rural community, it's the fact that they can't keep doctors. Doctors come and then they deal with this really complicated population that doesn't have private insurance, and they're gone within 6 months or a year. So continuity of care for a lot of these folks doesn't exist. And then the prisons drop people off. It's one of the cities in this county. It's the sickest cities in California, and the prison, they just drop them off. And so you can imagine, without any services, so you can imagine what happens within 6 months or a year. I went and with a team, and there was a house that had been occupied by a man who was on meth with his 2 kids, and nobody was taking care of them. So they finally evicted them, and we were digging out. And it was pretty heartbreaking to be digging out diapers and toys, and it was just a pile of mess. And we were trying to help the person who owned it, who herself was sick, and the neighbors didn't care. And they're surrounded by people who have all sorts of addictions. So I was just talking to a woman there, and they just got a grant to do home care visits, community care, the same kinds of care that you read about in Paul Farmer's work in Haiti with Partners in Health. And so Americans, of course, think that they're just so much more advanced than other countries. And we literally need the same types in certain places, the same types of forms of, NGO-based grassroots kinds of care that in the poorest countries in the world. And so I agree with Maria Elena that at the state level, at the national level, they have to be attentive to these regional differences, because they're significant. And again, the language differences are significant in different parts, like Oakland, I'm thinking of, there's Chinatown in Oakland, or other types, Japantown and other places. These kinds of places need different types of care. So I completely agree with her that we have to have scaled up approaches, handling different levels of care and different kinds of approaches of care.
When you think about that, and you think about the community health, is the the kind of increasing emphasis on the quote unquote telehealth. I don't have a more modern, we were talking earlier about how this makes us think about modems from our youth, but there's got to be a better name than telehealth. But is that something that you think would be helpful here, or does that create more problems of its own?
I'm going to hand it over to Maria Elena because I think she has the best data on that.
I haven't directly been studying telehealth. I have a great colleague here, UC Merced, who's been really diving into this issue. I think what we know about racial health inequities is that new technologies do not inherently eliminate the inequities, that you really have to address what the root cause of the inequities are. And so I think telehealth is like absolutely a solution. Like, we need to make that available to people, because some people, some clinicians do not want to be in person. Same with the patients, but it just creates a brand new context where the same barriers to healthcare can play out, whether they're linguistic or some of the more the issues around provider biases. Those all can play out in the telehealth. I don't know, Zoomosphere. Zoomosphere.
Yeah. There's an interesting thing in about that, and it's again, it in some sense, telehealth kind of perpetuates the problems. There's this thing, one of the challenges is having new patients over telehealth. It turns out, in the nitty-gritty of medicine and Medicare reimbursement and Medicaid reimbursement and all these other things. But there's this concept of continuity of care, which says that if you have a patient that if you don't see them, they're going to be in trouble, or you've seen them before, then you can see them under other circumstances. It's justified. And so if you're in the health system, you're more likely to continue to be in the health system, be it a telehealth system, or actually a go to the doctor's office system. If you're not in the health system, you're more likely to not be in the health system. And so it's an interesting thing as we've seen this emergence of telehealth, and then the challenges of billing, but not just billing, but also appropriate care by physicians. It's just quite different if it's ongoing care than if it's new. And so that's going to just have a dramatically differential impact on communities. Great. So one, there's I don't know if you have a chance. I have one question. Do you have questions for each other? We've been asking questions from the audience. Sorry to sort of throw something out a little wild, but so think about that as do you guys have questions for each other? Anything that comes to mind?
I think that we were asking a bunch of questions of each other before we got on, but I don't know, I would rather, respond to the people who are here.
There's so many great, I'm not following the chat, but I keep seeing them pop up. Yeah. So it looks like there's some great questions coming in.
Well, one of them was about what do you think would produce the largest change? I mean, if the Biden administration or the state government could do something in terms of a policy, what do you think would make the largest difference in what you see in terms of this impact of racial and socioeconomic status and their differential impact on health?
So I want to echo what Maria Elena said, which is, you can create new systems, but the racism and the stigma is just going to persist. So when I teach my race and medicine course, I tell my students that disparities are the result of death by 1,000 cuts. There's no one thing. For example, I was just reading in the newspaper, and it just strikes me as, I don't know where this story is going, but the NFL recently gave out money for these injuries to the brain. It turns out that they had racialized measures, which meant that Black people somehow were measured as having less of the players were less impacted by, and you're like, how does race and racism creep into everything, And so when I studied sickle cell patients and sickle cell disease and their treatment, so these wonderful sickle cell doctors were struggling to get attendings in the ER to stop seeing their patients as drug seeking or drug users. And so they created these charts, right? Robust charts explaining the pain protocol when they come into the ER to get the subjectivity of the nurses and the attending physicians out of the equation, So they just focused on treating the pain. And it still didn't matter. They still gave pain medication to, to other folks. And in fact, I assigned to my class, there's a television series called Lenox Hill, which is a documentary series on Lenox Hill. And I was watching it, summer, COVID, I'm watching it. And episode 7, I want you all to, if you're bored, to watch episode 7 on pain. And there it was, what I wrote about, the treatment of this Black patient by this physician. It's classic. So you can, in the same way that since COVID started, people have been saying health disparities. And now we're at the point of giving vaccines. And what are we saying? Vaccine disparities, vaccine. In all that time, we didn't plan for this. There's a lack of somehow connecting the dots between, oh, this is a real thing, and then what do we do about it? And somehow things get lost in the process of institutionalizing responses. And we keep repeating the same old. So again, it's death by 1,000 cuts, and we have to handle it by plugging up all of these various holes, from poor medical school education around these issues, which is getting a lot better. Medical schools are inviting in a diverse group of medical students who will change the discourse. I already see it. They are changing the discourse, right?
Yeah, that is really, it's amazing, actually. The medical education has become much more diverse, and it's more diverse than other than PhD education, than other forms of graduate education. Graduate medical education is really, I think, among the most diverse of our advanced fields. That's absolutely right, Colin. Hopefully that will help. It's interesting. Right before you said it, one of the people in the group here, Rachel Tellez, class of '93, said, "When are we going to stop describing disparities and start dedicating research to solutions?" And then it was great. Yeah, it's really true. We can spot all the problems and then not figure out how to identify them. And even in telehealth, it's still video chat, so you still are going to, I would imagine, have the similar biases to that.
Well, and as you said, it's even worse because you haven't really met the person.
Yeah.
Right.
It's all two-dimensional, and there's something about the way a person, there's information there. As an anthropologist, language is only a partial part of how we communicate with one another. We communicate in all sorts of ways. And so, you lose that. So you do need to know the person, I think, in order to do sort of robust telemedicine. And I completely agree with that.
So one question I had, we've talked about these various disparities and talked about the federal government and immigration, but one thing that I wanted to sort of mention a little bit is housing and housing policy. We heard a talk in this SWOT Talk series maybe a year ago or even more now by Josh Green, who is a Swarthmore graduate, class of '92. He's Lieutenant Governor of Hawaii, and he's been doing a lot there to combat homelessness. I wonder where that housing policy is in these challenging issues that we're talking about.
Well, so I can speak to what I've been learning here in this rural part of the state. I mean, first of all, in California, the cost of housing is the single largest expense that any family struggles with. And so in the interviews that we've been conducting with Latino immigrants, people are deferring any other cost, including the cost of food, to be able to continue to make rent payments. And I think despite the eviction moratoriums that are in place, people are onto it. The moratorium will be lifted at some point, and they don't want to be amongst the millions of people nationwide who really are at risk of eviction. And so the burden of housing right now is an incredible barrier to sort of all other areas of well-being, whether it's nutrition or sort of even the simple things like, I know one of the interviews I remember the family talked about the cost of car payments, and they were an undocumented family, and they'd gotten essentially sort of burdened with this predatory loan for a car because they're undocumented, and so now they were literally stuck between sort of defaulting on this loan for this car payments or paying their rent. So I think, I just think the cost itself is a big issue. But what's interesting, I think in rural areas in particular, where you live is a huge determinant of access to services. So, I mean, here in the Central Valley of California, we have major issues with just access to having water, like clean drinking water, sort of the basic kind of amenities that are, kind of take for granted in urban areas. And so I think a housing policy really is kind of at the core of people's ability to have a stability, financial and material, to then be able to engage in other, aspects of their lives that can promote health.
Carolyn, do you want to comment on the housing question?
So again, what if we saw economic inequality as a health issue? What if we acknowledge that, when you have billionaires have enough money to destabilize poor nations, this is it's a weird thing. And it's a whole cultural construct. We built that system, we can take it apart. And so the result in the Bay Area and California is you have people who have money they literally could burn and still have billions in the bank. And that makes no sense. I remember that was one of the things I learned at Swarthmore, is that nobody works, 1,000 times harder than somebody else, 400 times harder than somebody else, So you have these systems where, people can live well, and other people can't afford a basic house, and that's not good for health. It's not good for anybody. And so absolutely housing is critical. And it's not just the housing itself, but it's also the whole, it's garbage collection, it's environmental exposures, it's policing, just policing. It's all of it. It's foodways, it's community centers, it's mental health, help for mental health. There are a lot of mental health issues in poor communities because people with mental health issues tend to be poorer, right? So it's all of it. But I just think that we have to let go of this. It's kind of like a lottery economy where, you're hoping to make it big for no reason other than luck. But it's really built on nothing, and it's producing a lot of misery for a lot of people. So I hope we rethink all of that.
We're nearing the end of our hour. Might be a chance for you each to, if there's something we haven't covered or something you would like to kind of say as a kind of final thing. Maria Elena, is there something that you would have wanted to get across that we didn't ask? Or
this is not a closing thought or anything, but just one more thought, because this has just been such a enriching discussion. And I think it's some points, Carolyn, you've been making about just sort of how we think about inequality. The research shows that inequality is bad for everybody. So when we have, greater economic inequality, the richer in the country, and this really, I think, Carolyn, speaks to your work, there is solid population health evidence that even the wealthy do worse than in other countries that have less inequality. And I've seen that with some of the work I've done looking at immigration policies. States that have more inclusive policies towards immigrants, everybody does better, not just the immigrants, this US born citizens also. So it really is more, we can think about it as, racial, socioeconomic, citizenship inequalities are something that, has an impact on the entire population, not just those at the bottom of the hierarchy.
Absolutely. And I think, one thing that's really interesting, when Americans think about their wealth, they think about their house and their car. They don't think about the air that they breathe, the water they drink, the roads that they drive on, the community, the local library that they have. We're so focused on this sort of form of individualism that we falsely equate with freedom. But actually freedom is for me, freedom is the freedom to not lock my door and not worry that I'm going to be robbed. My freedom is knowing that I can, put my garbage on the corner, and garbage collector is going to do this great job of collecting it, and I'm going to try to do my part to recycle as well. That's a form of wealth too. The school system is a form of wealth. And so I wish Americans would see their wealth beyond what we've been trained to think is the thing that we bought, right? It's about time. It's about space to be able to make a meal for friends and family and community. It's so much more than simply our house and our car. So I just wish that people would start thinking in that way, as I said, and to think about we can do it. We have the technology to actually measure care. We can actually pay people, right? I know that Chang, he ran on the platform of like the give people $1,000. I'm not so much a fan of that, but I think that I'm a fan of the idea that we can actually pay people who are taking care of a parent who has dementia. That we could find ways to do that, and I could see that as a part of the future, and it would help the community where I work. Anyway, I'll stop there.
Well, that's terrific. Thank you. I think thank you both so much.
Thank you, Ted.
Really, it's great to be back at Swarthmore, at least virtually, and to bring the years together. I know we had we're from the 80s, Carolyn, you and I, and Maria Elena from the aughts, and I know that we had someone from the class of 60 ask a question, and someone from the class of 73 make a comment, and in all eras, and even the 90s too, I think, got in on it. So it's really really terrific. And so Dr. Carolyn Rouse from Princeton University in anthropology, and Dr. Maria Elena de Trinidad-Young, who's at University of California, Merced in public health. Thank you so much for this tremendous discussion, and keep up all your energy and enthusiasm. And I hope we can meet on campus sometime in the not so distant future for an alumni event. It would be terrific.
Thank you.
Thanks
Thank you
everyone.
all.
130
And
people
thank
here.
audience. Thank the audience.
Thanks everybody.
Thank you all for
Bye-bye.
coming.